Good evening, good afternoon, everybody, and welcome from Switzerland. I am very pleased to participate to this third meeting. I would have been delighted to come to Greece, but unfortunately, I'll do that later on, I guess, to the ERS meeting. So it's an exciting afternoon, and I thank the organizers very much for having me with you. And so I will talk about nasal functional measurements. Before I go straight to the topic I was given, I just want to really recall that the nose is an organ and has many functions. So, and this is usually mistaken by many colleagues, physicians, but also ENTs. They think the nose is just like a pipe system where air goes through. So many of these functions you see here, I will not go deeper into it. Some other people this afternoon will talk about that. I will go for breathing mainly and just summarizing the functions like breathing, conditioning, smell, defense, all that stuff. That is very important. And I just want to really stress, if you go home and you keep that in mind, that the nose is an organ, I'm happy already with the afternoon. So consequently, rhinology is a medical surgical discipline. There is no such thing like rhinosurgery. You know, a rhinologist is somebody that has a nice job. He's doing a medical job and surgical job. That's a privilege in medicine. You can do both. And there is another message I want to place is there is a measurement tool for nearly everything in the nose, and all these functions you can see there, one can measure them. The question is not so much can we measure them, the question is much more, are they all really good, quick, and reliable? And I'll go through breathing, airway, and address also these questions. First, I just want to have an advertisement of this position paper done by the Rhinology Society, the European, the ERS, and this is free downloadable. It's roughly 40 pages, very nicely done. It's a good overview of what can be measured and what's state of the art and what's available in nasal measurements. Now, let's come to the topic I've been given is breathing, airway. So the main thing we want to have as physicians is a satisfied patient. So the patient, and most patients come to see us say, I have an obstructed nose. They want to be satisfied after whatever you have done. So that is our main outcome measurement is satisfaction. Now, if we want to address that, and that's what probably most of us do, we go for asking, or you can say visual scaling or numerical scaling, but that is easy to do, of course. It's subjective. That is the shortcoming. And the problem, we all know that it's not always correlated with anatomy or endoscopy. And I just wrote there, it's difficult to assess. Now, most of you would say, yeah, but what is so difficult? If I ask somebody to rate whether his nasal patiency is poor or excellent, that looks easy for people who have done an academic courses. You can even do it like more stringent and say, please cross one of the numbers. It gets a little easier. However, keep in mind that not all our patients have a high school degree, and not all of our patients are used to fill in questionnaires. And just to show you some anecdotal things we have experienced in the past, there are shortcomings. You know, if you do a rating and you ask people to rate, so you would naturally think I put a cross or a bar somewhere, but there are people doing putting other signs there, like many bars or waves, but it can be even more fantasy-like with bars, lying bars, waves, or even ECG curves, or writing. So there is basically no limit to how people can fill in these kind of questionnaires. So that's probably not that bad, but it's not perfect as well. And it has some shortcomings. So to go back to the Renaissance, we should try to make measurable what can be measured, and when there's no measure, so we should try to invent a measure, or go for a measurement. So when I come back to breathing, what is breathing about? So most people would intuitively say breathing is about the air has to go through the nose. That is true. That is the physical airflow. And that's what I'm going to briefly give an overview. But there's another thing about breathing. Breathing is also perceiving the air going through the nose, because that gives you a feeling of comfort. And this is a sensory perception. I will not talk about that. There is Thomas Hummel and Jordanis who will talk about that. If you want to go for physical airflow, you want to have a measurement that addresses this kind of stuff like septal deviation. That's our daily job. And you would like to have a measurement that can give you some numerical values for this kind of deviated conditions. But it's also about measuring mucosal congestion. This is a view, a frontal view of a nose. You have the septum, the turbinates, the middle turbinate, the inferior turbinate, and you can see how different this is, whether this mucosa is decongested or whether it is congested. And these are the questions that we would like to address. Is it mechanical like this, or is it dynamic? Is it just a mucosal swelling? Okay, how should we measure nasal airflow? We can do that. I will go from simple to more sophisticated. We can do that very semi-quantitatively and very easily. And one of the best instruments are our fingers. You can take your fingers. You can, for instance, palpate the columella. You will feel with your fingers. Fingers are, by the way, a sensory organ, whether the septum is deviated or not. You can also do the Cottle maneuver. You probably know that. You go for widening the nasal valve region, and you will find out whether this relieves the person or not. There's another easy to use tool. That's the Glatzel mirror. I will show that. You put the mirror under somebody's nose and he exhales and gives these breathing spots. So that's quite semi-quantitative, but it helps you if you have no more sophisticated manners to do that. If you want to go for research or values you can print and put in a file, it's easier to have numeric kind of measurements. And I'll go through three types of measurements that have, in a certain way, found their way into clinics. So one is rhinomanometry. The other one is acoustic rhinometry. And finally, PNIF, which stands for peak nasal inspiratory flow. So maybe just to show what the Glatzel mirror is. So this gentleman had a very severe deviated nose with a blockage of the left side. And as you can see, this is the mirror with the reflection of his nose. When he exhales, there's only condensation spot, a breathing spot on one side. So that's this measurement. Now, if you go for more numerical measurements, there is, I think, the most important measurement we all use, or we all have in our clinics, I guess, is rhinomanometry. Now, this is it's kind of an oldish picture, but it's not that bad. It more or less looks like that. It's a face mask with tubings going to the nose. Now, the probes put in the nose, they will measure the pressure, and the mask that you put on your face with the closed mouth will measure the volume. And as you can see on that graph, you have a volume measurement and a pressure measurement. And together with these two values, you can calculate the resistance. So you basically have three measurements with rhinomanometry: is pressure, volume, and as a resultant resistance. Now, that's a very nice tool. Problem is, it only shows you a kind of an overall resistance. You cannot say the resistance is generated by the middle turbinate. With this kind of measurement, you can say there is more resistance on the left side or on the right side, or both are symmetric, or the values are elevated compared to a normal population, things like that. That's the first thing you have to know about that. The second thing is, this is not a measurement that can be done out of the blue. Um, this is a measurement, so if you measure nasal resistance, it's something you need to put into a setting. It means you will measure nasal resistance, and then you will measure it again after having done something. For instance, giving drops that would decongest. So you could see whether the decongestant really decreases resistance. So why is that important? Because the nose is not always having the same resistance, because you have seen the swelling of the nasal mucosa can be variable. It changes over time. It changes from side to side. I will show that later on. And consequently, the nasal resistance is not a fixed issue. However, there are certain things that can be taken out of these kind of graphs. For instance, if you recall the septal deviation, so one side is then has a higher resistance than the other one. If you decongest the nose, the septum would not straighten because you decongested the nose. So you will probably still find this asymmetric resistance with the septal deviation. So there is a value of doing rhinomanometry by giving the information whether a resistance you measure is dynamic or reversible or not. And you can see that with these curves. You see this is the situation where the person has a congested nose. So you have the inhalation, the one side and the other side. And the person then, roughly, the more vertical these, the more horizontal these curves are, the more it is congested. And that's in between these two graphs, which is the same person, there have been drops administered, which are decongestant, and you can see that these curves become much more vertical, showing a decongested state. So that is clearly now mucosal congestion that has been reversed. As I stated, take care or consider the fact that the nasal mucosa is not something that is always fixed and is highly dynamic. So that this is what we call the nasal cycle. There is the nasal congestion on one side will be more pronounced during a certain period, and that during that period the other side is decongested, and that changes all kind of 3 hours. That is my nasal cycle I recorded a few years ago. You can see if you have the nasal resistance at point 0, so one side was very decongested, the other congested, and 4 hours later it changed, and so on. So that everybody has that, and that has to be taken into account when you do rhinomanometry. Let's switch to another measurement. Maybe some of it's less prevalent in clinics. It's called acoustic rhinometry. Some of you probably have seen that. It does not look that cumbersome anymore. It's a less big instrumentation, but the principle is the same. You send some acoustic waves into the nose, and similar to the echolot, these acoustic waves would bounce back into this to the rhinometry, and with some calculation you will be able to reconstruct the inside of the nasal cavity. So this measurement tool does not measure resistance. This measurement tool does measure anatomical landmarks and where they are located. So for instance, you can see it's the cross-sectional area of the nose and at certain distance from the nostril. So you can see, for instance, here you have the nasal valve, narrowest place of inspiration and the tip of the inferior turbinate. And of course, if you decongest the nose, this will change this curve, because these landmarks, maybe less the nasal valve, but more the tip of the inferior turbinate, they are to a certain degree, they are also changing with decongestion, as I showed you before. But basically, I must say this is a tool that has not went into clinical routine, I would say. It's used at big centers or with specific questions. Now, finally, there is the peak nasal inspiratory flow. Has been described years ago in the 80s. It's basically like the peak flow for the asthmatics, but it's the other way around. So you would not exhale like this. Everybody knows that. Every asthmatics know that. You exhale and you measure your peak expiratory flow. This is the inverse. You inhale, so you would just put the tool on the nose and inhale very quickly. And you see what is the peak you can get. So it looks like that. It's that's quite old literature. It has been rediscovered, I would say, during the last 15 years. There are lots of nice publications out there. You have normative values. You have a lot of other information you can get. It's very cheap. It's very easy to use, and it has a few advantages. It is one thing that is interesting is if you go for peak expiratory flow, which is a measurement of the lung performance, and peak nasal inspiratory flow, which is an instrument for nasal performance, they correlate well. So there are data out there showing that with the PNIF, you can also have kind of information about how lung works. And this is interesting for our patients. We often forget that most of our patients do not only have nasal problems, they also have lower airway problems. Finally, I showed you rhinomanometry, and if you go for a correlation between the PNIF and the rhinomanometry, it also correlates quite well. You can see that people who have low resistance in the rhinomanometry usually have high inspiratory flow performances. So it's a good tool. And that's the important thing. It's not a very costly tool. If you go for the acoustic rhinometry and rhinomanometry or the PNIF, that is really a big difference for a certain level similar outcome. So consider that. I think it's a very nice screening tool, and it should be used in a much wider way than it is usually currently done. Now, before I come to an end, I just want to add some general considerations about functional measurement of the airways. I'm often asked, what do you think? Is it mandatory to do that? Do I need to do that? Sometimes insurance companies ask me, we need a rhinomanometry before we accept that you can do surgery on that person. So that's kind of a very personal way, but I think one should keep in mind that questions about measuring nasal functions often always arise when symptoms are there. Nobody would think about measuring nasal function in somebody has no problems. It's different than the visual acuity. You do that also in normal people. It's rarely done in healthy subjects. That's what I said. And keep in mind that compared to visual or auditory system, the nose is an organ. I told you that. The nose is also a sensory organ, but we are really, really poor in how much we know about the nose. So we are measuring an organ we do not fully understand. So the second question is, how useful are these measurements? Are they mandatory? Do we need to do them on a regular basis? So again, some very personal considerations. Maybe we can discuss that later on. But I think, when is measuring useful? I think this is an important question. What does it tell you? What is the validity of the measurement? So is it a good tool? I think this is the key question. How reliable is it for a single patient? You can have measurements, you can have data, as I showed you for the rhinomanometry. They correlate. If you take a lot of people, they would correlate with what you see in the endoscope. But on a single patient, is it this measurement that would make you operate or not? So does it really change your practice? Is it useful to measure if whatever the result is, you wouldn't anyway not change your clinical practice? How is it done? Keep in mind that all these measurements, it's like a pure tone audiogram. It also depends on the technician and of the person who is interpreting it. And so if you are a physician who gets a result and you have no faint idea about what this measurement does, don't do it. You need to know what you measure. Does it reflect the complaint? It's a good question, I guess. Is it useful to monitor improvement or care? So Why do you measure? That's the basic question. So let me give you one example, and then I'm basically almost done. This is a septal deviation. This is rhinologist's job. Huh? You can see right nostril deviated, left side wide. Do you do surgery or not? Does the rhinomanometry help you to decide whether you want to do surgery? So my answer would be probably not, because your decision whether you would do surgery in this person or not has been taken long before you would go for rhinomanometry. It's probably based on if the person complains and what you see, the endoscopy. Let's consider that this patient complains of nasal obstruction, but the septum would be extremely straight. It's not like the one you see in the picture. Would rhinomanometry help you then? Maybe it would help you to tell the patient, listen, your resistance values are extremely normal. Maybe it would help you to say, it's maybe not airway, physical airway problem. Maybe it's a perceptual airway problem. And maybe you would go for other measurements. So I think the rhinomanometry, for instance, in a single patient does not always reflect the complaint, and it has to be set into something. That's what I wanted to show with this example. You need to think about why you want to do that measurement, and will it bring you further in your pathway, clinical pathway. Should we do routine measurements? That's something I'm often asked. Do you do a rhinomanometry in all the patients you will operate on? Let me state a few things. So routine measurements, I think that's useful if you want to run studies, but that is academically motivated. Some people tell me, I do it for legal reasons. That's fine, but that's defensive medicine. That's something we're struggling with. It's extremely expensive, okay? And I think it's worthwhile talking about that. We don't do it on a regular basis just for legal reasons. And I must say that what I've often seen, it's rarely done, measurements like rhinomanometry, PNIF, and so it's rarely done to improve patients' workup or care. It's usually done for studies or because people are frightened of something. So make your measurements only if it changed something in your care pathway, or if you want to do a study. And there needs to be an indication for a nasal measurement, like for a surgery, I think. Just for the very frightened people, medical legal problems related to not measuring, that goes into the category failure to diagnose. That is very rare, very rare. That is something that you don't need to be afraid of. Most people who get sued, it's because they did a surgery they are not able to do, or because they didn't told the patient what conclusions were, and so on. So forget about that. Okay, to summarize, I think I'm pretty much into time. There are many ways to measure airway function, from simple to sophisticated. Measures are a part of total evaluation and rarely the only parameter you should rely on. What is the question you are addressing, and what should the test answer? So is the test a good test on an individual level, then it is clinically useful, or is it a group level? That's much more important to know. What test should only be done if it changes something, and I think it needs individual pragmatic evaluation whether you want to test or not. And with this wonderful view from Mont Blanc from Geneva, I want to thank you for your attention, and I hope you have some questions.